right, good afternoon, everybody. We are going to get started. George, you're here. Okay, well, good to see that you're back online.
Yeah, I mean, the good thing was the PC did a system restore and brought it back
Okay,
to us.
okay, great. All right, so I see who else is online. I see Cassandra, Bethan, Orisha, and that's Tashane, right? Map student. That was Tashane last time, so I'm guessing it's Tashane again today. Okay, yes, hi. And we have Keon in the classroom. All right, great. So today we're talking about aging and the changes in sleep patterns. And we have a few learning objectives that I'm going to just go through. All right. So we want you to be able to provide a brief description, very brief, of sleep architecture. We're not going into any of the fancy details, just an overview so that we understand, we have a basic understanding of what sleep architecture looks like. We are going to also talk about some of the main differences in sleep patterns that occur throughout the life course. So how is sleep for a child different, from sleep for an older person? And we're going to talk about the relationship between certain factors and sleep in older persons. And then hopefully, after looking at all of these things, you should be able to make some recommendations for improved sleep for persons based on their particular conditions, for older persons that is, based on their particular conditions. All right. So when we talk about sleep architecture, we are talking about the basic structure of normal sleep, right? So this is not, where any disorders are. This is just a normal sleep and what the normal structure looks like. Now, sleep seems to be a simple thing. We just go and lie down and close our eyes. And for some of us, almost immediately. Some people, it might take a longer time. And it just seems like, we don't have to make any effort. But it's actually a very, very complex state. A lot of things, happen. And it's actually the research interest of a lot of persons from a purely physiological standpoint, to persons who are interested in how it affects other aspects of life. Some people just want to know scientifically what is happening, all the brainwave activities and so on. And then you have persons who take a step further to look at how that impacts health and disease. There are basically two types of sleep. There is non-rapid eye movement sleep, or non-REM sleep, and then there is REM sleep, or rapid eye movement sleep. Now, for non-REM, it's divided into stages. All right, so they break it down, and that's characterized by what happens during the stage. So there are basically four of them. They used to call them stage 1, stage 2, stage 3, stage 4, and they've sort of revised the terminology, and so you will hear N1, N2, and N3. But each stage, each type rather of sleep, so that's the REM, non-REM, has its own identifying features in terms of brainwave activity, in terms of what we see, for example, when we actually look at the eye of a sleeping person, and the muscle tone. And so this helps us to distinguish between the sleep state types. Now, REM and non-REM sleep actually alternate, during a typical sleep cycle, and that repeats itself about every 90 minutes. So let's go now and look at non-REM to start off. So this is where you would start sleeping, right? It's described as a state of deep sleep. It's dreamless, all right, usually, right? So typically no dreaming occurs there. And like I said before, it alternates with REM throughout the night. In terms of brainwave activity, when they observe the brain, you have what are called delta waves. These are the slow moving waves These are what's happening in terms of brain activity at that point. And also, there's a low level of autonomic physiological activity. So, you know, the type of thing that you don't really actively have to do. So, like your heartbeat, your breathing, and so on. That is going on usually at a lower rate. Sometimes you might see non-REM sleep also called slow wave sleep. Now, it's considered because of what is happening, it's thought of as the stage of sleep where your mind rests and your body heals. So this is the restorative sleep, right? This is the sleep that is supposed to be good for healing us, all right? Now, we spend about 3/4 of our entire sleep time in this stage. You're saying something, Tashin? Or you're waving to somebody passing by? Okay, all right, that's fine. So we spend about 3/4 of our sleep time in this stage. And as we begin to fall asleep, this is where we start with non-REM sleep. And we go through the different stages of non-REM, starting with N1. So N1, usually, sorry, not usually, formally called stage 1, is a transitional phase. This is between being fully awake and falling asleep. So right where you start to drift off to sleep, you know, you cannot, you're still aware, you know where you are, you know who you are and so on. But you know that you're kind of drifting off, right? It's at that point, it's very easy to be aroused back to wakefulness, all right? It's very easy to wake up. So it's considered to be a light sleep. Then after you go through that stage, you go into N2, which used to be called stage 2. This is now where sleep is really starting, right? So we're not transitioning anymore. We're actually sleeping and you're becoming disengaged from your surroundings. Also, fairly easy to be awakened during that stage. So it is still considered to be another part of light sleep. By this time, your breathing and your heart rate regular to slowing down, and also your body temperature starts falling. Then after that, we go to N3, which is basically a combination of what they used to call stage 3 and stage 4. This is your slow wave sleep. Excuse me. And this is where, when they, you know, they monitor the brain activity, this is where they observe the delta waves. These are the slow moving waves. And they're all, you know, that if you look at the graphs, you'll see them. That's what the brain is doing. This is the deepest and most restorative sleep. You know, people believe that your health is actually jeopardized if you don't get to spend enough time in N3. Blood pressure drops, breathing becomes slower, the muscles relax, blood supply to the muscles increases, and you know, it's basically just really shut down at that stage in terms of your body. Tissue growth and repair occurs. So this is part of the restorative process, right? Because your body now has started to heal itself. And hormones are released, such as growth hormones and other kind of hormones that your body needs. All right, so that's non-REM. Then after that finishes, now you start into rapid eye movement. Excuse me. Now this is so named because there is actually rapid movements of the eye underneath the eyelids. And I'm sure we've seen that sometimes when you know look at somebody sleeping and you're seeing their eyes darting back and forth. So that actually happens at that time. We spend about a quarter of the night in REM, but of course remember it is cycling between REM and REM, so it's not an REM. Sorry, between REM and non-REM. So it's not it's not like the whole 25% one time. So that's what happened. Now, this is where the mind energizes itself and the body is immobile. So your body, your brain is very active at this time, right? So remember, we're coming out of REM, non-REM, sorry. non-REM where slow brain wave and, you know, a little bit going on there. But in REM, your brain is very active. And this is actually now where you dream, okay? Which is why, I guess, the slowing down of the muscles and so on occurs, because it could be pretty dangerous, right? If we were to have our muscles, you know, in full use with all that activity going on in the brain, we could probably be acting out some of our dreams, which may not be the best thing. And in some disorders, persons actually do that. And we know the implications for that. So pretty much in normal sleep though, your muscles are turned off and your mind is energized. All right, so that's just our brief overview, and we're not really expecting you to know anything beyond this. If you do, then great, but this is just the basic understanding of the two main phases, types of sleep, and what happens in them. All right, now sleep is very, very important for the good functioning of your body. There is a bi-directional relationship between sleep and health. So, for example, as illustrated by this little diagram here, sleep impacts your different body systems, and it also impacts quality of life, overall quality of life, and mental health. But then these aspects of health can also impact sleep, because sometimes when there is some kind of malfunction in some system, it affects your ability to sleep. Or if there's something, you know, awry with your mental health, for example, it can also affect your ability to sleep. So it goes both ways. I just want us to be able to appreciate that kind of a relationship. And we're going to look at some other things later on. But just to highlight what happens as we get older, or maybe I should more correctly say, what happens at the different stages of life with sleep. With the newborns and infants, you know, just as almost everything about them is not fully developed, so the sleep cycle is also not fully developed. So at that time, you know, the normal rhythmic patterns of many things, including sleep, not fully entrained. So the first few weeks of life look very different in terms of sleep architecture from older persons. All right. Now, when I say older person this time, in general, I mean the broad use of the word, not 60 and over, just anybody who is older than an infant. All right. So these little ones sleep about 16 to 18 hours per day. Of course, this is not continuous sleep. This is broken up. And in fact, according to most studies, the longest sleep episode that they have at this time is going to be about 4 hours. All right. Their sleep types are termed a little bit differently from what we just spoke about. They talk about quiet sleep, active sleep, and indeterminate sleep. Quiet sleep is pretty much similar to non-REM that you would have in older person, okay, be careful, I use the term older persons now, in people older than infants. And active sleep is similar to REM sleep. Sleep starts with REM for newborns and infants, which is different from what happens with children upwards, because children and everybody older start off with non-REM sleep. By the time a child gets to about 2 to 3 months, the circadian rhythm develops, and so their sleep cycle matures and they start to look, I almost said more normal, but you know what I mean, you know, more typical of the general sleep pattern that adults have. There have actually been only a few studies in young children, but they tend to agree that as children get older, so when you're comparing the young children to the babies, for instance, the amount of sleep decreases. That can happen for two main reasons. It might be due to physiologic requirements, so what you actually need now as a child of, say, 5 years versus a baby of 2 weeks, you know, in terms of what your body needs for its development, that can actually change. Also, there are cultural and social changes that will also affect that. So now you're going to school maybe, or preschool, watching TV, talking, playing, and so on. So there is more engagement and therefore less sleep time. In young children, sleep preferences actually start to emerge. And so you might have those who like to stay up a little bit later, or those who get up, you know, with the sun, kind of a thing. So your night owls and your morning birds start to emerge, even as they're getting a little bit older. Young children actually have a lot of disturbances in their sleep due to dreams, sometimes bad dreams. So you know, they have difficulty with that, so you might have broken sleep. They also have problems, some of them, initiating sleep, so that is falling asleep, might take a little bit longer to fall asleep, and also staying asleep can be difficult too. Young children also might take a longer time to get to rapid eye movement sleep, and they might actually spend longer in deep sleep, right, than others. Adolescence is another phase that brings a lot of changes to sleep. And of course, a lot of this is related to pubertal development. Persons believe that when you're trying to understand sleep, it's better to look at persons' pubertal stage rather than their chronological age, because that dictates, you know, the changes in puberty dictate what happens during sleep. Adolescents require 9 to 10 hours of sleep each night. For them, short-wave sleep declines with development. They also take a longer time. Sorry, the sleep latency time is longer. The sleep latency has to do with how long it takes to fall asleep, right? Now, what is happening here is that there is a lot of daytime sleepiness with adolescents. And so then that will affect what happens in the night. Afternoon sleepiness is greater than in late afternoon and than in evening in more mature adolescents than in younger subjects. So all of the changes that happen at this time is largely to, you know, like in the Caribbean, we were saying when the teenagers are sleeping, we say, you know, they're growing, you know, and, you know, it sounds trivial, but there is some truth to it, right? It's not necessarily growth as in height per se, but there are developments taking place that actually require sleep. I remember as a teenager, I used to sleep a lot. I mean, I still sleep a lot now, but I used to sleep a lot. So, you know, coming home, for me, the biggest thing, I never used to like, you know, hanging out after school. That wasn't me. I would do my 1 or 2 extracurricular activities, you know, walk around the town for a little bit. But my biggest thing was just to go home and to sleep. Yes, that was the biggest thing. And I would sleep for about 3 hours, and then I'd wake up and watch game shows, like Wheel of Fortune and Jeopardy, that sort of thing. So I, you know, I know for sure that sleeping a lot, you know, is necessary. I needed that rest for my growth and development. With increasing age, the total time spent sleeping actually decreases. But they do believe, though, that if bedtime is fixed, then REM sleep, which tends to decrease as well, can actually remain constant. So getting yourself in some habits is always useful, because that can help to set the sleep pattern. With adults, younger adults may experience brief awakenings. These are usually minor. And the good thing, though, is that they come close to the transition. So it doesn't really break up the sleep per se. It's not like you're waking up while you're deep into a particular phase, but as you're transitioning from one to the next. And so it doesn't affect it as badly. As people age, however, from say from age 20 to age 60. Short-wave sleep, I remember we said short-wave sleep is a restorative sleep, the sleep that your body needs to rejuvenate itself and so on. Short-wave sleep actually declines at a rate of about 2% every 10 years, right? So what happens is that older adults actually experience more frequent awakenings during one sleep episode. All right, they wake up more. Now, the reason that happens is that during short-wave sleep, right, arousal threshold is very high. That means it's difficult to get you to wake up. Okay, but older persons actually spend less time in short-wave sleep. Now, this is the time when it's hard to wake up, right? Arousal threshold is high. They spend less time in short-wave sleep. Therefore, they spend more time in the stages where the threshold is low. And so they actually they're easily aroused from sleep several more times than persons who are younger. And I'll just interject this because as I was talking, it just popped into my head. You know, sometimes, I don't know if anybody here has ever read from the Bible, Ecclesiastes chapter 12. A very, very interesting passage of scripture. The language makes it also very interesting because it's so, remember it's written in a you know, older type language, like Old English. So it's not how we would normally express ourselves today. So this is the part of the Bible that talks about, remember now they are creating the days of their youth, before all these things happen. Now, if you look at all those things that happen, it's things associated with old age. And one of the things that's there, you know, there are things about, you know, your teeth falling out, talking about your grinders being few, that's your teeth actually falling out. And then there's something about waking up at the sound of the bird, right? Yeah, which is what would happen if you're a light sleeper or if you're somebody who wakes up early in the morning. So it's very interesting that, you know, this old manuscript would talk about these things. And now, you know, our research is showing that it's actually an old age thing where people sleep lighter, wake up easier, and actually don't spend a lot of time in sleep. When you get a chance, have a look at it. It's actually an interesting, if you're into poetry, I guess it would be more interesting to observe, you know, the language and how it is expressed. Anyway, that was an aside. But so older persons have more sleep disturbance because they spend less time in that phase of sleep where arousal threshold is high. They also experience changes in circadian rhythms that reduce sleep efficiency. So it's pretty much, you know, bad. For older adults, more specifically now, we know that sleep disturbances can happen at any age, right? And regardless of how old you are, if you're not getting good quality sleep, it's gonna have a negative consequence on health. But this becomes particularly important for older persons because they have a lot of other things already against them, right? And we speak about how important it is that, you know, that sleep is for health and well-being. So it's almost as if, you know, everything, the odds are really being stacked up against you. Older persons typically show an increase in disturbed sleep that can negatively impact their quality of life, their mood, because, you know, when you don't get enough sleep, even for younger people, if we don't get enough sleep, we can be a little bit on edge, you know, a little bit miserable, and so on. It also affects your level of alertness. Studies have shown that older persons, that's those 60 and over we're talking about now, spend 36% time less time, 36% less time in sleep than children, say, at age 5. The ability to sleep also becomes more difficult. But, you know, I think because we realize that, for example, babies need a lot more sleep than young children, you know, and young adults. Young adults need less than adolescents. We always tend to think that the older you get, the less sleep you need. But that is up until a point, right? Because the research actually does not. All right, we're getting a little bit of feedback. All right, I think we should be okay now. The research doesn't show that the need to sleep decreases with age, right? Certainly not for all adults. We all still need it. With older persons, generally speaking, most of them will report some kind of difficulty, whether in falling asleep or in staying asleep. But what the researchers have observed is that persons who have other comorbidities, so for example, persons suffering from depression or respiratory illnesses or have some kind of physical disability and so on, they are more likely to report difficulty with sleep than other older persons who are in good health. And generally, decrease in sleep quality has also been observed. More research findings: older adults 65 to 75 years typically awaken 1.3 hours earlier than younger adults, say in the 20 to 30 year group. They also tend to go to bed one or so hours earlier. Tushi?
Can you hear me?
Yes.
Okay, it's because I was having mic issues, so we fixed it. I'm sorry to disturb you guys. Just
okay, yes. So we realized something was happening, but we're fine now.
All right, then.
Okay. There has also been some observances of sex differences within sleep. So for example, for women 70 and older, 15 to 20% of total sleep time is spent in stage 3 and 4, whereas men of the same age spend about 5% of the time in those stages. That can be problematic for these men, right? Because we know how important that restorative sleep is. Older women tend to go to bed and wake up earlier than older men. And some of this is believed to be linked to body temperature rhythms. We know also other changes such as menopause affects sleep and sleep quality. So women who are postmenopausal women tend to have a lot of disturbances in their sleep, lots of nighttime awakening, and sometimes that has to do with, the hot flashes and the other just general discomfort. They tend to have a lot of sleep disturbances. Some of them actually have difficulty falling asleep, and then when they do fall asleep, they don't sleep for very long because they wake up early. Both men and women have increased stage 1 and decrease REM sleep. So generally speaking, if we were to sum up all of those changes, we find that from birth to adulthood, there are changes in terms of how sleep is started and how it is maintained. We also observe that there are differences in the percentage of time spent in the different stages of sleep, and also in the overall sleep efficiency. What they've observed in terms of sleep efficiency is that it declines with age. All right, so what you understand by sleep efficiency? Just think about what you know the word efficiency to mean, and what you know what sleep is, and then try and put it together. Sleep efficiency.
So I guess that would be like quality of their sleep. What's the quality of their sleep?
Quality, you're saying?
Yeah, or in what kind of the quality of their sleep.
I want to turn up Arisha.
You could hear me now, Dr. Tinde?
No, I think it's probably on our end, so I'm gonna we're trying to do it here. Okay, there we go. All right, go again, Arisha. Let me see.
So I was saying
Yes, thank you. Sorry.
It explains like the quality of sleep of that older person.
The quality of sleep of the older person.
Yeah, for their sleep efficiency. So the quality of sleep that they get would decrease with age.
So when you hear efficient, you think of quality.
Also order. You're looking at input and output.
All right. So let's work with that one. I prefer that. Let's go to the what is
Okay.
going on? So let's build on that.
Input and output. Okay.
Oh, go on, Arisha. Oh, I know. Let's
Okay.
build on the input and output argument. There we go. Okay.
So I guess how much sleep is actually put in, um, and then what they actually get out in terms of the efficiency as an adult, as an older person, based on how much sleep they actually get.
Okay. All right. Tashane is trying to come in.
I just wanted to say probably how well they how well they sleep, miss, or how rested they are after this.
All right, all right. So we have more people leaning in on the quality of the sleep. Um, Efficiency is a bit different from quality. That's why I was trying to push Arisha to work on the input output argument and see if we could build from there. But okay, I'm going to give you some numbers, and you tell me. Let me try and see if we can figure out what they mean by efficiency, right? So let's say I go to sleep at 10 p.m. Okay? Sorry, start over. I go to bed. I climb into bed at 10 p.m. I get out of bed at 6 a.m. Right? Now, I climb into bed at 10. I didn't fall asleep until 10:30. And I got up at 6, like I said. And I actually woke up at 6 and got up. Yeah, I woke up and got up at 6.
Okay.
If you were to think about that and think about efficiency, how would you relate the efficiency of the sleep?
With the number of hours you stay asleep.
And let's throw something else in the mix. I get up to use the bathroom and I woke up a couple of other times just randomly. So I spent another 30 minutes awake between going to the bathroom and just randomly waking up. So when you're thinking of the efficiency of the sleep now, you have to, what they actually do, and I'm not saying that this is the only way of measuring it, but the way that they measure it is by looking at the time that you actually spend sleeping as a fraction of the time that you spent in bed. So if I go to bed, not sleep, bed, at 10, get up at 6, that's 8 hours, right? But 30 minutes out of this was spent actually trying to fall asleep. So that's my sleep latency. And then another 30 minutes was spent, between going to the bathroom and the random waking up. So there's 1 hour there that's not spent in sleep. So they would put the time that that time, which is the 7 hours, over the 8 hours, and then they work out as a percentage and give you the sleep efficiency. So that's typically how they do it. So it's efficient sleep. If I were to just climb in bed, fall asleep right away, sleep for the whole time, don't get up, don't use the bathroom, don't wake up randomly, and get up at 8, then I'll have 100% efficiency because I'd be in the bed for 8 hours and sleep for 8 hours. But if any time is subtracted from that, then your efficiency becomes less than 100%. All right, understood? Mm-hmm. So that sleep efficiency declines with age because the number of hours you spend asleep. Mm-hmm. is less because sometimes they actually go to bed and they take a long time to fall asleep. Sometimes they wake up, you know, to use the bathroom wholly, yes, and just also randomly, you know, the dog bark and they wake up and that they stay awake for 1 or 3 minutes. They hear, you know, a sound outside. You know, that's me when my husband is not at home. I hear everything, literally everything I
Everything.
hear.
Okay.
Yeah. So that I get really, really bad sleep during those times.
I wonder
But
if there's disturbances between the cyclical REM to non-REM sleep, because that also get disturbed. So again, I was wondering if that has a factor in the efficiency, I mean, of quality of
go,
sleep that is gone.
go again, George. I didn't hear the
I
first
mean,
part of it.
when we sleep, we go through a cyclical REM, non-REM, I mean, non-REM, REM, non-REM. And so
Right.
when we disturb that rhythm, I was
Oh,
wondering, yeah, I was wondering
yes,
if that also plays in a factor of actually the
for
body.
the efficiency. Yes, yes. Yeah, because if, for example, if you're supposed to, you know, successfully transition, but somehow during that you wake up, you know, it cuts out, or if you're not going in the right order for whatever reason. Mm-hmm.
And another thought that I was just reading about, I mean, some time ago, I was reading about normal aging. And there I read that the circadian rhythm of the older persons fall 1 hour earlier, which exactly is what we say, which was mentioned in this lecture, where they sleep 1 hour earlier.
Yes, yes, and
So,
wake up 1 hour. That's where was it? Here. Yes, typically awaken 1 hour earlier and go to bed.
yeah.
So less. It's like punishment. So sleep is vital for human development, we've seen, and sleep is critical for successful aging. So the fact that these things are, it's almost like a catch-22. You know, you need sleep for successful aging, but then these things are happening as you get older. So that's challenging, you know, the attainment of successful aging. So it gets pretty difficult. All right, so this is a, what do you call this now? Stacked chart, area chart, yes, stacked chart, showing changes in sleep with age. So on the y-axis, we have time in minutes, right? This is time spent in sleep in minutes. So if you look here, it goes all the way from 0 to about 550 minutes, which is somewhere over 8 hours. If we can divide that by 60, I'm not sure what that works out to be, but somewhere there. And then on the x-axis, we have age going across from 0 to 85 years. Now, what we have here is different attributes of sleep that are important. So if we just focus, you can see that they're shaded in different colors, right? So we can focus on each area separately. And we can look at the change that occurs with sleep. So for sleep latency, anybody remembers what I said sleep latency was?
Time taken to fall asleep.
The time taken to fall asleep. So what is happening with sleep latency from age 0 to age 85?
Increase.
And remember how to read this. You look at you can look at the width of the thing, because the top line here is relative to this. For example, if you wanted to read off a time in minutes, it would be, can you see the, oh, you're not seeing the thing. How do I get, oh, no, I wasn't there moving the cursor, thinking that you could see, but let me get the pointer. There's a pointer thing. We can see this now. Okay, if you are going to try to read off a time in minutes, for example, for here, it would be, let me just one since it's bigger. So let's say we're in the shortwave sleep section and we're trying to read off a time for shortwave sleep at 10 years. We'd read this point minus this point, and then we'll get the amount of minutes, right? The number of minutes. That's how we'd calculate it. it will be this point of 410 minus 220, and that would give us how many minutes we're talking about here. All right. So, but anyways, back to the general pattern now. Sleep latency has to do with the time it takes to fall asleep, right? So pretty much constant for children, up to early teen. Then it starts to fall off. Notice it's also the width of that thing is narrows, right? That means the time is shrinking, right? So that means that our teens to young adults don't take no time to fall asleep, right? Head hit the pillow, gone. But as you get older, notice it starts to open up again. So older persons take a longer time to fall asleep compared to their younger counterparts, for the most part, their younger adult counterparts. All right. The next thing is wake time after sleep onset. That's a WASO. So again, that's bad for the older person, as you can observe here. Not much, very, very short time that's spent awake after initially falling asleep for the younger ones. But as you get older, then you spend more and more time awake after you have initially. So this is difficulty maintaining sleep, right? That's what that disorder would be. Difficulty maintaining sleep. Not much change, I would say, for the stage 2. Nothing grand, for the stage 2. I mean, yeah, it might be a little bit lower here than here, but not much grand. It's almost, you could almost imagine a straight line across, and so not much change. But the short wave change is very, very obvious. Look how much time a young person spends in short wave sleep compared to an older person. Look how the graph starts crunching and shrinking down by the time you get to the late 60s, 70s. And so this is what we were talking about, the challenge for body systems repair, cellular repair, because the time when you're supposed to be spending in that restorative sleep is actually much, much reduced as compared to younger persons. And so I guess, this is just how it is. Senescence, right? So we can't beat that. And for REM, you notice it also shrinks, but not as marked as the deep sleep. Okay. So this is what it looks like. Everybody comfortable with the graph?
Just remarking at how, during your youth, you spend a lot of time, creating your life, whether for one reason or another, you're doing work, you're doing studies, you're doing family, whatever, and you deliberately minimize your required sleep. And then when you get older and the perception is that you have a little bit more time on your hand, you may be retired, etc. You don't want to sleep anymore. You don't need as much sleep.
Yeah, and then sometimes we train ourselves, for instance, most people who I talk to, faculty, most people are doing 4 or 5 hours of sleep per night. Most people say that they're good with 5. They can definitely function with 5. But sometimes, depending on what the pressure situation is, there are people getting 3, 4 hours of sleep, and that's not right. And it's like people's everyday life, which is crazy, Then gonna come a time now when we want it, our bodies will not allow. Yeah.
And then there's also a consideration for people who do night work, security, law enforcement officers, and various industry work. And they forever, reverse. And then when they get into retirement, it becomes, or the change starts to become very difficult as well to readjust.
Yes, that's true. And there are some experts who say that the nighttime sleep yeah, it's different, and it's better. It's what your body needs. So yes, you get the same number of hours per, in the daytime, for argument's sake, but in terms of our bodies, I guess you can reset your circadian rhythm, but in terms of the body's circadian rhythm and what it does at certain times, that nighttime sleep is really what it needs. Who knows? All right, so now let's look briefly at sleep disorders. There are many distinct sleep disorders, a whole lot of sleep disorders. But more often than not, we see some of the common symptoms. But of course, they would have their different nuances. You have excessive daytime sleepiness. Yes, that's a disorder. Okay, so you find yourself sleeping all the time in the daytime, you need to see a sleep specialist. Difficulty initiating or maintaining sleep. Abnormal movements during sleep, abnormal behaviors and sensations during sleep. So there are different disorders that can be categorized around these symptoms depending on how they manifest. There are also other conditions that are not sleep disorders per se, but they affect sleep and sleep quality and how people are able to sleep. So for instance, you might have dementia, where persons who have dementia have been observed to spend less time in deep sleep and REM sleep. You have persons who have loss of different sensory functions, for example, vision or hearing and so on, that can cause confusion at bedtime. So they're also a bit disoriented, and so they don't fall asleep when, for example, it's nighttime, because they're not aware that it's nighttime, and so all the other signals and cues that their body should have been taking, they're not getting those, and so it poses a problem. Don't know if anybody has ever seen this advertisement on cable. Non-24, people who have Americans have a name for every condition, right? So there's this condition called non-24. Has something to do with your 24-hour circadian rhythm. I remember exactly what they said. But blind people apparently have issues with that a lot. And it's again due to inability to perceive nighttime and pick up the cues from the environment and so on. And of course, they were advertising a pill for that, right? Because there's a pill for everything. There are other physical disorders that can affect sleep. For example, pain disorders. Those are huge in terms of affecting person's sleep, causing them to have difficulty falling asleep or having them wake up during sleep. There are also things like breathing disorders that can affect person's ability to maintain sleep. And then there are also mental health issues that can affect sleep too. So for example, if people are worried or if they're afraid, anxious, and for whatever other reason they might be unsettled, that can also disturb your sleep. So let's look a little bit more at some of these. We're going to look at the type of disorder or situation. So we had some categories here. We're going to look at the type and look at some examples there. Look at the symptom that they might have that actually affects the sleep, and then some possible treatment or some actions that we can take or that can be taken to address these. So for example, dementia. I'm not sure why dementia is on the physical, but anyway, let's look at dementia. Dementia can come with confusion, paranoia, agitation, and wandering. And so recommended treatment for that is trying to improve sleep behavior or giving sleep aids. So sleep, whether it's medication or teas or something. In terms of improving sleep behaviors, things like routines can be very, very useful. Bedtime routines. So there are things, and people do it with children too. There are things that they do before you go to bed, and so you get to associate that with sleep. And so that should encourage sleeping. Also, exercise is believed to be very, very useful. Not immediately before bed, because then you might actually get too stimulated. But with enough time between, so that you can get to sleep healthily. Sensory loss, as we talked about earlier, that can cause confusion too, and they do for that possibly taking melatonin for people who have vision loss or for people who might need to correct any kind of sensory problems. Osteoarthritis, that gives low back pain or that gives hip pain. Sleeping with a pillow under the knees or under the hips can help, because then it relieves the pressure on the back and on the hips, and so it can make the person more comfortable. Also, if you do exercise to strengthen the muscles in that area, then it might help to get some relief. For persons who have issues with reflux disease, gastroesophageal esophageal reflux disease, so you might have chest pain and heartburn, then for that, don't eat like about 4 hours before going to bed. So that way, you give time between your last meal and sleep, so for it to be digested. The other thing that works really, really well too, and this is from personal experience, as I'm telling you this, is setting your bed at an angle. So you make the bed head higher. And you can use pillows to do that too, but putting the bed on 2 blocks literally is like a lifesaver. And that gets your body properly angled so you don't have the flow back. That helps. And of course, there are antacids. You can always pop a pill for everything. For persons who have BPH and they might have urinary incontinence too, they're affected. Their sleep can be affected by the urge to urinate. Whether it is they actually want to go or it's just urgency issue. So they might there are several different urinary symptoms. So it might be just frequency. It might actually be urine loss. But essentially, all these things happening, breaking up your sleep. What's recommended? Emptying the bladder before you go to bed. Also, not drinking, again, like about 2 to 4 hours, so you get enough chance to pass out everything that's there. Avoid certain things like caffeine, which we know, promotes urination. I don't know exactly what it does, but anyway, promotes urination. So cut off the Coke, cut off the coffee, especially, late in the day. And then there are some medications that you can take also for that. For persons who have heart failure, they might suffer from a cough, shortness of breath, palpitations, chest tightness, and all those things that, of course, can disturb your sleep. So taking medications for heart failure will help. Also, using a pillow again to prop up the body, I guess that will help with the breathing. Other things, anxiety. So, for example, people might have nighttime worry and agitation. Counseling can help. I know we're not the people who readily go for counseling. Yeah, it's for some reason looked on as you're crazy or you're weak or something. But counseling helps because you get somebody who's a professional who will help you to process things, and a lot of things are irrational, and sometimes you just need to get those things worked out. Or again, you can take anti-anxiety drugs. Depression and bereavement, that can cause excessive sleepiness, right? So it might be that you just want to just lock away in this world because you don't want to face whatever is causing the problem, and so you just want to just sleep your life away. So excessive sleepiness, some people actually can't sleep because of the depression or the bereavement, or they have sleep disturbances, so they don't really sleep for very long. They wake up early in the morning and so on. Again, counseling can help with that, antidepressants, and other ways of just handling, bereavement, because these are natural parts of our existence as humans. You're all going to have something that happens that makes us sad. So we have to learn how to deal with grief. For persons who have post-traumatic stress disorder, they might have nighttime panic and they might have nightmares Again, counseling is very useful here. Sleep aids as well can help, so the person will actually just stay sleeping. There are also some social conditions that can affect sleep, and we have to be aware of these too. Isolation is one of these social conditions. This can affect sleep through causing frequent daytime napping. It can also persons can also be afraid to sleep, for whatever reason. You're isolated, you're feeling all alone, you just want to stay awake. And I kind of get that one too. When I'm alone, I tend to delay sleep as much as possible. And that's probably because when I go to bed, I know I'm not going to sleep sound. So I try to stay awake for as long as possible, so that by the time I go to bed, I know, okay, I'm going to be knocked out. So, for whatever reason, that happens. So to address that, spend time with other people or arrange for supervision during the evening. Sometimes people just need somebody else around, and that can help. Sometimes changes in surroundings, that's another social issue. Changes in surroundings. So for example, if somebody has been relocated to a different house, or they've gone to a nursing home or something, that can affect their sleep. Maybe they actually can't fall asleep, or they spend the time, worrying about the issues. Sometimes we can address that by decreasing daytime napping, because you have other people. For example, sometimes you go to nursing homes, depending on nursing home, and everybody just there sleeping. I'm like, I'm sleeping all day, what they do in the night? So, one strategy is to actually try to reduce daytime napping, try to get them engaged in other things so that they're less likely to sleep. Also, persons advise that you don't use the bed for anything other than sleeping. That will train your body to recognize that, okay, when I'm here, it's sleep time. So don't, watch TV in bed or do work in bed, carry home work and do work in bed, that sort of thing. Leave the bed for the sleep space. Persons also use white noise machines. Sometimes people use that with babies too. So, that helps to get rid of the outside traffic, in terms of the noise that's around, and creates this quiet environment where a person, relatively quiet environment that you can fall asleep in. Lighting is also important too. And so you have to think about what the room looks like that you're sleeping in. Because sometimes it just needs to be a little bit darker or a little bit quieter, and that can encourage sleep. So there are some very practical steps that you can take depending on the nature of the disturbance. Sometimes it might be a simple fix, like turn off the lights or make the room cooler or something like that. But sometimes it might require a little bit more, like going to counseling or taking medication. There are a whole bunch of sleep disorders. This is 1, 2, 3, 4 of the more common ones. We've been talking about insomnia, but we've mentioned it several times so far. Difficulty falling asleep or staying asleep through the night, that's what it looks like. There is also sleep apnea, in which persons experience abnormal patterns of breathing while they're sleeping. And there are lots of different types. So for instance, somebody might gasp for air, while they're sleeping. There's also restless legs syndrome, which is that sleep movement disorder. There is just this sensation and the urge to move the legs while they're sleeping. There can be medication for that. There's also narcolepsy, which is characterized by extreme sleepiness and sudden falling asleep. So this is just a FYI slide really on some of the common sleep disorders. But one of the important things that I want you to be able to talk about is some of these disorders or some of these social situations that can affect sleep, and how they affect sleep. So the type of sleep-related symptoms that's experienced, and also what can be done to address it. All right, so that's where I wanted to focus here. All right, so this is an abstract that was taken from, what's this? This is the Journal of the American Geriatric Society. This is a little reference here that you can read, screenshot up here. Not the full article, of course, just the abstract, but we just want to look at it to see if we can find out about some of the research that has been done looking at sleep and dementia risk. So this paper is called Association Between Daily Sleep Pattern, Duration, and Risk of Dementia and Mortality in a Japanese Community. All right, so the objective, Tashane, can you read the objective for me and tell me in your own words if you know what you understand from what they were trying to do?
The objective is to investigate the association between daily sleep duration and sorry, my background is a bit noisy. All right, so the objective is to investigate the association between daily sleep duration and risk of dementia and death in a Japanese elderly population. And I'm supposed to do what next?
Tell me what you get from that, what you understand from what they were trying to do, expressed in your own words. What are they trying to do?
All right, I've said that the objective, as you said in my own words, is to make a link between how long the person would sleep during the day. So the link is between that, how long they sleep during the day.
During the day, as in during the daytime?
Yes, if I'm understanding daily sleep. No, well, this says daily sleep durations. I think it would take in sleep time as nighttime sleep.
Okay.
Well, that's my understanding. So the link would be between that and the risk of dementia and death. So how long they sleep, whether daytime or at night, whenever it's sleep time, how long they sleep for that period, how does that affect or how that's linked to, I don't want to use the word contracting dementia or dying. I don't ever use the right word when I say contract.
All right, and how likely is it that they will develop dementia,
Right.
or that they will die?
Right.
Right. Okay, good, good. All right, so the design, it says here, it's a prospective cohort study. Cassandra, you want to tell us what you understand from that prospective cohort study? Cassandra not with us. All right, Karine. Karine, it's a prospective cohort study. What do they mean? All right, Karine is also not with us. Arisha?
All right, so the perspective forward would mean that they're.
I'm here, but I'm driving.
Oh. Hello?
Okay.
Dr. Tyndale?
Yes,
Dr.
Karine.
Tyndale?
Yes, Karine.
I'm here, but I'm driving.
Oh, so okay. All right, that is all right. Arisha is going to answer that question then.
All right, so the prospective cohort study
All right.
that they're going to follow the people up. So they have an exposure, and they're going to follow them up going forward. If it was retrospective, that would mean that they would have to follow them. They would have to follow them in retrospect. So that basically means prospective, meaning that the study is ongoing at the moment. So that's current.
Okay, so tell me who are these people then? Describe the people that are in the study in terms of what kind of information they would have on them and what they'll be looking for.
So basically they would have, that would be the Japanese elderly population, and basically they would have how much hours they sleep. Right? And
yes.
what they're looking for with them, they're looking for the risk of dementia. So they're looking to see if they will get dementia based on the amount. So the exposure here is the amount of sleep, and they're looking to see if they will get dementia. So they follow them up until if they do get the outcome, which is the dementia.
Or death, right?
Yeah,
so at the point when they're starting the follow-up, does anybody in the study have dementia?
No.
Okay, and has anybody died?
No.
No. Okay, all right, good. So prospective cohort study, they're going to enroll a group of people on whom they will get information on sleep duration, and then they're going to follow them up for whatever period of time, I don't know how many years, and then they're going to check at intervals, and then perhaps, whatever the end point is, for example, at the end of 10 years, maybe every 3 years, and then finally at the end of 10 years, and they want to see how many persons have developed dementia and also how many persons have died. All right. The setting, so this is the Hisayama study in Japan. Okay. Participants, community-dwelling Japanese individuals age 60 and older without dementia. Community dwelling, what you understand from that, George?
A set of people living in one area, in one locality area, and who are over 60 years of age.
So they all have to come from the same community?
I want to believe, because there should be some common characteristic for them to be included as a cohort.
Okay, so what if I am doing a nationally representative cohort study? And I'm saying it's a nationally representative community-based cohort study. Certainly everybody couldn't come from the same community.
Oh, yeah. So, yeah, it can be from different communities, but the age or something, the common characteristic can be the age in this situation.
Right. So the common characteristic would be, of course, their age. They don't have dementia and, whatever else. But community dwelling here is community dwelling as distinct from, say, for instance, living in a nursing home.
Yes.
Right? Or, hospitalized or in prison or whatever. So whatever kind of institutionalization, that's just saying that they're actually free living in the community and not institutionalized wherever that might be. Nursing home, prison, whatever, hospital. Okay, so measurements. Self-reported daily sleep duration was grouped into 5 categories, and those are listed there: less than 5, 5 to 6.9, 7 to 7.9, 8 to 8.9, and 10 or more hours. And then it says the association between daily sleep duration and risk of dementia and death was determined by Cox proportional hazard model. All right, so let's not get hung up on that. That's just telling the type of statistics that they use, but essentially they're trying to calculate, risk, and this is the way they did it. The proportional hazard model is just looking at what we call time to event, but we're not going to bother about that. We're just focusing on the important thing, which is just understanding that they're trying to estimate your risk of death or your risk of dementia based on the amount of sleep that you get. So they'll get from each person how long they slept, and then they will they'll group them, right, into these different categories. All right, so let's look at the results now and see if we can try and understand it. Again, just a basic understanding. During follow-up, so that's during the follow-up period, and whether it was 3 years or 10 years or however long, we don't know. What we'd need to do, ideally, they should have given us the follow-up period in the methods, right? But what we would want to do here is to get the full paper to read, and we get all of those details. We don't have that now. But during the follow-up period, however long it was, 294 participants developed dementia. So that was one of their outcomes. And 282 persons died. That was their other outcome, death. Age and sex adjusted incidence rates of dementia and death were significantly greater in subjects with daily sleep duration of less than 5 hours and 10 hours or more than in those with daily sleep duration of 5 to 6.9 hours. Keon, what is that saying? Yes, read it again. Mm-hmm. Just tell me the main finding that's there.
Right. So they were saying that age and sex adjusted incident rates of dementia and all-cause mortality were significantly greater in subjects. So for subjects that had sleep durations less than 5 hours and 10 hours, they had higher incidence of dementia and all-cause mortality. And they were higher in that group, meaning the group that had sleep durations of less than 5 hours and 10 hours.
Hold on, read that second part, the 10 hours part. Read it properly.
Hold on. And 10 hours and more.
So remember the categories? Look on the previous slide with the sleep categories. They had 5 sleep categories. Less than 5, 5 to 6.9, 7 to 7.9, 8 to 9.9, and 10 or more. Right. So 10 or more was a category by itself.
Right.
Yeah,
so they're saying that the incidence of dementia and all-cause mortality were greater in subjects with daily sleep duration of less than 5 hours.
One category?
Yes, and of 10 hours. And they were more in those with daily sleep durations of 5 to 6.9 hours.
No, man. What number 10 hours and more is a category, you know?
Oh, 5
yes.
hours
and 10 hours and more. Right.
Sure.
Positive.
Than
100%.
Those with daily sleep durations of 5 to 6.9 hours.
So what they're doing here
is
comparing, yes.
The one group which is less than 5, one group which is 10 and more, and then another group which is 5 to 6.9.
Right.
Right.
So both the 5, so 5 is being compared to 5 to 6.9, and 10 or more is being compared to 5 to 6.9. Okay.
And they're saying that in the groups that got both less than 5 hours and 10 hours and more, there was greater incidence of dementia and all-cause mortality, right? It was significantly greater in those two groups than in the group that had sleep between 5 to 6.9 hours.
Right.
Right.
Right. Everybody sees that? So it's almost as if too little sleep and too much sleep is bad as compared to getting 5 to 6.9, which is, I guess, optimal in this, according to this study. Because the risk of dementia and the risk of death from any cause, that's what they mean by all-cause mortality, were greater in those two groups. In the group that had less than 5 hours, and in the group that had 10 or more hours. Okay, so that's the take home. Okay, should I even mention this? They actually give us the actual risk, right, of death, and they also said that they adjusted it for age and sex.
Right.
What that means is that they've taken into account the effect of age and sex. Now remember that we said age can affect age can affect your sleep, yeah? Age can also affect your risk of dementia and your risk of death. As you get older, you're more likely to die. As you get older, you're more likely to get dementia. If you're a man, you're more likely to die sooner. I'm not sure what the sex and dementia relationship is. And so they would have to adjust for those characteristics so that when they have these results, they can say, okay, we have taken age into consideration. And it's not because they were older. It's only because of the amount of sleep.
Right.
Right? So what they're saying is that, listen, people who got too little sleep, so less than 5 hours, were at a greater risk of death compared to those who got 5 to 6.9. And people who got whole heap of sleep, 10 or more, were also at increased risk of dementia and death compared to those who got 5 to 6.9 hours. And they actually gave us the level of risk, right? So, for instance, let's see, less than 5 hours, your risk of death was 2.6 times greater than the risk of somebody who slept 5 to 6.9 hours, right? That's what this 2.64 means. For dementia, right? And for death, it was 2.29. So more than twice, so you're more than 2 times likely to die if you had that less than 5 hours of sleep compared to somebody who had 5 to 6.9. Right. So this is what we call a U-shaped relationship. So let me show you a U-shaped relationship, right? So let's say, I should have changed the color to white, but what is the thing? Death, dementia.
So for
I'm putting DM for dementia. And I'm putting,
goes by, or number of hours
sleep.
It decreases after 5 hours, which would be where the top of the U is, right? The very first arm would be about 5 hours. So risk of death would be on one side.
Right. So this is like 5 and lower.
Where?
Here, the first one.
Yeah.
All right, and then your risk gone up again when you reach 10.
When you reach 10.
All right, so this is what they're talking about with this U-shaped relationship, right? So there are some points where, so this is the risk of dementia and death. They both look the same, right? So your risk is high if you're on the lower end of the sleep scale, hours of sleep scale. And then this is the optimal range where risk is low. So it is somewhere between, 5 and 6.9. and then your risk starts to go up again thereafter and gets very high again at 10. So this is the kind of U shape that they're talking about there in the text, right? So so it says here, similar U-shaped associations were observed for Alzheimer's disease and vascular dementia. So they actually looked at, they didn't just say dementia broadly, they actually separated it out. They looked at hypnotic use, but I'm not sure how they measured that, but let's just see what the finding says. With regard to the influence of hypnotic use on the risk of dementia and death, subjects who used hypnotics and had any sleep duration had a risk of dementia that was 1.66 times as great as the risk of death. That was 1.8. And the risk of death was 1.83 times those who did not use hypnotics. Okay, so hypnotics is bad. And had a daily sleep duration of 5 to 6.9. All right, that's not our concern. So the conclusion then, short and long daily sleep duration are risk factors for dementia and death in Japanese elderly adults. So that's the take-home message, all right?
I think the second part was saying that those who used hypnotics and those who did not use hypnotics, having the same amount of sleep time, 5 to 6.9, those who used hypnotics had 1.66 times great risk of death and dementia than the ones that did not use any hypnotics.
Okay, subjects who used hypnotics and had any sleep duration regards to the sleep duration had a risk that was 1.6. Oh no, so they're comparing. Oh no, so here they're comparing use of hypnotics. But then what they're actually comparing is any sleep duration, regardless of how long you sleep, compared to what clearly is their reference category that they've chosen of 5 to 6.9. So using hypnotics and sleeping for any amount of time, your risk was 1.6 times. Your risk of dementia was 1.6 times greater than persons who did not use hypnotics and slept for 5 to 6. And then use of hypnotics and any sleep duration had a risk of death of 1.83 times greater than those who did not use and slept for 5 to 6. Right?
Yes. They're just saying that the result of that is, I think they concluded that hypnotics will increase the problem of dementia.
Right.
That is one of the conclusions, I think.
Right. Why would they compare the use of the hypnotics and any sleep duration? Why would they compare the use of a hypnotics and sleeping from 5 to 6.9? Because it seems to me, because obviously, based on what we're seeing here, there is a relationship between the amount of sleep you get and the risk of death and dementia. So I'm saying if you're going to look at the effect of hypnotics, then you should, control for the number of hours of sleep. To me, if you want to see or isolate the effect of the hypnotics alone, because then you can always say that if they're using hypnotics and you get less than 5 hours per sleep, let's say most of the subjects got fewer than 5 hours of sleep per night, then you would be left in your mind.
Not separated out.
Yes, you're not really sure whether or not it's the hypnotics or the low sleep that is causing this increased risk.
Yeah, and I'm not sure why they did it that way. I guess for me, I'd want to see the full paper where the method section to say why they did this classification, because this is just hypnotics versus hypnotics and sleep of a particular time.
Right. Yes.
So not sure why they thought that was the best way to do it. Right. So sorry.
No, I was just putting also, generally in clinical practice also they say it is not good to give a sleeping aid to persons who are on the risk of dementia because that can just worsen it. So,
And also, I mean, sleep aids in
so that,
general,
yeah,
older persons is very,
the risk of dementia increases, they say.
So, oh, so then I'm just trying to think about why they would have done the analysis like that. So maybe they're just comparing the non-ideal to the ideal.
but we know it can't not ideal. They've already
But,
discovered
but
that.
they want to quantify it. They want to quantify the amount of risk. So the ideal
is no hypnotics.
is
and
no
5 to
high
6.
hypnotics and 5 to 6. So let's compare that with people who use hypnotics. I don't know, I'm just guessing. I don't know. I'm guessing.
Because we're expecting to see that.
I don't know why they use the word hypnotic. Did they mean hypnotic or sedative, or if both they're using that interchangeably?
Yes, I think so, George. Well,
Yeah.
I think.
Karen says she thinks so. She
Okay.
thinks it's being used like that. So again, when we have all these, this is why we never read the abstract alone, right? And try to make any huge takeaways from it. We will now, after having read the abstract and it piqued our interest, we would now say, okay, let me find this full paper and try and see, so I can fully understand the methods and can fully understand what they did. Actually tried to get it, but it wasn't free. And I didn't feel like buying a paper today, so I didn't try to get it. Right, so that was that paper. Yeah, so this is where we end for today, unless there are any questions. Sorry, go ahead, Tashane.
No, I don't have a question. I'm sorry.
Oh, okay. Saw your light coming on.
Yeah, sorry.
There are some nights I would wake up in the morning and I would think, oh yeah, I dreamt all night last night. But then you realize that only 25% of the sleep is actually REM sleep.
Yeah. Sometimes I wonder if I'm really getting it, as orderly as that, because I do understand that. I felt like that too. I felt like you actually have had several dreams, and they feel long. Sometimes you're like, I really dreamt the whole night. You wake up tired. Well, I wake up tired when I dream too much.
Though.
Yeah.
Because that dream sleep is the same, which is REM, right?
Right.
That's one, and then that's the one that you're not at your most restful.
Right. State. Yes. So when you have too many dreams, that you probably have spent too much time in REM, and maybe compromise your non-REM, and so you don't feel refreshed and revived and that sort of thing. So I actually prefer not to dream.
Yes.
Yeah.
Just one last thing. I'm sure, these other guys can agree that treating sleep disorders in older persons is a very, very challenging thing, because you want to do right by them. You know that they don't sleep a lot, but most times, especially persons who already have a diagnosis of dementia and so on, the relatives are, they want the older person to conform to their sleep pattern, which is typically an 8 to 10 hour type of sleep, and so the older person may be sleeping for 4 or 5 hours, and it's not enough for them because they're waking up at all kinds of hours of the day or night and disturbing their sleep. And so it's almost like you're forced and backed into a corner a lot of times, I find, because you're there trying to, it's a tug of war between what you know to be correct and to be completely normal versus what the desires of the family are.
Yeah, that can be pretty tricky too.
It's tricky, and
especially if I guess they're probably on a lot of other medications.
they
You don't want
are,
to add.
and sometimes there's a bit of aggression, but I mean, I know that can be handled a different way, but they get confused at night, they get disoriented sometimes, so it's not just about being awake and lying in bed. You know, they get up and they're disruptive and they do all sorts of, you know, so it gets very, very challenging for families sometimes, and for caregivers.
I know a situation with this husband and wife, and the husband has dementia, and of course, so he barely sleeps at night, and the wife would wake up and he's just standing over her and staring, and she's like, it's very disturbing, you know, because you don't know when something is just gonna go off, and then you know they just do something weird. He was just standing and just staring at her the whole time. But it's hard. But at least that's not bad, right? Because he could be doing a lot worse. He could be doing a lot worse in the
All kinds of things, including wandering away.
Yes.
And also recognizing that they need to go to bed 1 hour earlier than the others.
Exactly.
Yes. Since they're getting up 1 hour earlier.
Right? I have a senior and the husband has dementia and he would sleep for the entire day. And when it's night, the wife has to stand beside the bed for him to just squeeze her finger for the whole night. And he'd call her just to make sure she's there every night. And it's one something because he would sleep for the whole day. And when it comes to night, he's awake and just lying there. And she has to give him her finger for him to just play with her finger. That's all he would do. Put it in his mouth or just squeeze it for the whole time, and she would kill her. But as she moved, then call her as she moved.
So I wonder what they've tried though to get him to reverse that, because clearly he's sleeping, but he's doing it in the daytime. You can get him to switch.
He's fast now, but his illness deteriorated quickly. But I mean, he passed a few weeks ago, so I mean, she bear with him a whole lot.
Yeah, it's a rough one to have to deal with. And sometimes you really feel helpless, you know? You don't know what to do. Yep. All right, guys. So remember your objectives for this session and use that to guide your revision. And if you need to consult other sources and so on. All right, so have a good afternoon or evening.
You too, Miss. Thank you.
You too.
Bye. Bye.
Bye.
Bye.
Bye.